Hello everyone. So today my class will be on the topic endotracheal tubes. I hope we all have a better understanding of endotracheal tubes after our class. Let's begin. Sorry. Yes. I would like to start my class with a shlok from Bhagavad Gita. I want all of you to once try to read it and see if you can understand and gain some positivity. Okay. So here in front of you on the screen this is an endotracheal tube. Okay. Uh, so before we move on, I would like to give an overview about an endotracheal tube. This end is the patient's end. This goes inside the patient. This end is the machine's end, and this lies between the both ends. Okay. In the patient's end, there is a bevel. This is the bevel. There is a Murphy's eye. All right. Then we can see a cuff. Connected to the cuff is an inflation line, and this is what we call as pilot. And pilot has a one-way valve. When we inject air inside the pilot, the cuff on the patient's end gets dilated. All right. Then we have the tube. The tube has lots of markings on it, as we can see. This marking which is written, which mentions 7.0, is the internal diameter of the tube. Okay, there is a radio opaque line present on the tube. It also has some significance. We'll discuss it later in the class. And then comes the machine end. Machine end has a connector. Okay, endotracheal tube, we use it daily. We use it. It's our bread and butter. The endotracheal intubation, we induce all the general anesthesia cases with this. We use it in emergency. Anywhere where there's a compromise in airway, we use endotracheal tube. Yes, there are other devices also to secure airway, but all of us most commonly use the endotracheal tube. All right. Now, moving forward, we'll discuss each and every part of an endotracheal tube in depth. We are going to discuss types of endotracheal tube. We are going to discuss with what material it is made of. We are going to discuss the cuff. We are going to discuss its volume, and we'll try to discuss some special tubes at end of the class. Okay, which we might or might have not seen in our day-to-day work life. Moving on. Okay, the endotracheal tube, also known as intratracheal tube or tracheal catheter, is a device that is inserted through the larynx into the trachea to convey gases and vapors to and from the lungs. A cuffed tracheal tube, once placed, provides the perfect protection for the lungs, and the tube is least likely device to be dislodged. It is most preferred way of securing airway in most places. Alright? Okay. Like I mentioned, the parts of endotracheal tube. Alright? We can see there's a patient's end, then there's a Murphy's eye, there's curve of the tube, there are markings, there's tracheal tube material, there's a tube size, tube cuff, and a proximal end. Okay, we are going to see each and every part of this in great depth. All right, moving on. Yes, talking about this part of endotracheal tube, we'll try to zoom it a bit. Okay, this part of tracheal tube which we see on the end, this is the bevel. This, I'm so sorry. This part of the tube is the bevel. What does actually bevel do? Okay, so this bevel is, as we can see, this bevel is not straight. All right, if you try to draw a line and a central line, this bevel is not straight. It is slanted. Okay, which side does this bevel face? It faces the left side. The bevel, when you insert an endotracheal tube, the bevel is present at the distal end of endotracheal tube, and it faces left when it is held anatomically. When you hold a tube anatomically, the bevel faces left. And how do we insert the tube? We take the blade. We hold the handle of the laryngoscope. We put it. We deviate it, and we enter from the right side. All right. Why do we enter from the right side? We enter because there's a better visualization of larynx from the right when we enter from the right side. So when you enter the tube inside and you place it anatomically, the bevel will face the left. And I will also it is worth mentioning the bevel. Wait, I'll show you in this slide. Uh, this bevel actually, when it is slanted, it makes an angle with the tube. I'll try to mention it makes an angle with the tube. Okay, the bevel makes an angle with the tube, and that angle is approx 38 plus minus 10 degrees. Yes. So we have learned how in which direction the bevel faces once put inside. What is the angle it makes with the endotracheal tube, and now we'll discuss the functions. Why there are so much modifications in the bevel and what are its functions? So basically, when the bevel, because of the bevel, the way bevel is made, it helps in easy facilitation of endotracheal tube while intubation. Okay, and also while you're intubating, you can have a good view of the glottis, the vocal cords. You can have a good view of vocal cords while inserting the tube. Third, while sometimes there are when there are situations where we have to do nasopharyngeal intubation, this reduces the nasal trauma. All right. Okay, so that's it about bevel. We'll move forward. We'll come from distal patient end to machine end one by one. Okay, so first thing we discuss is bevel. Now coming forward, sorry. See, I'm not very good with gadgets and recordings because this is the first video for composed anesthesia I'm recording. Okay, so I'm gonna make lots of mistakes. Also, I'm gonna look little dumb to you, but please go with me. We will grow together. One day, I'm definitely going to make high class videos. I hope, I imagine. But now, for now, this is what I have: a mobile phone, an iPad, and one laptop in front of me, and I just know how to use PowerPoint, and with that I'm trying to make this channel. I hope it is clear and you get a better understanding. Okay, so we talked about, so from now I brief you what all went till now. We discussed endotracheal tube in an overview. We discussed the parts of endotracheal tube. Now we are discussing the bevel of endotracheal tube. Now we just discussed the bevel of endotracheal tube, and now we will go forward. All right. Now this is the next part of the tube. This is the Murphy's eye. Okay. I'll show you in this diagram. This part that you are seeing, this. Okay. This part that you are seeing is called the Murphy's eye. Okay. So does Murphy's eye lie on the same side of bevel? No. Murphy's eye lies on the opposite side of bevel. Okay. So, what is the significance of this Murphy's eye? See, the biggest significance is if this tube, for some reason, imagine, gets blocked here due to any reason. It could be a mucus, it could be due to positioning, it could be due to laparoscopic abdominal insufflation, it could be due to anything. So, whenever this tube gets up, this Murphy's eye become the passage of air, passage of ventilation. It continues the ventilation despite the tube getting blocked at the bevel. Okay, so we can say it is also acts as a secondary port. It acts as a secondary port. Now, what are the these are the advantages, and now what are the disadvantages? Imagine, due to something you are trying to do, in there, sometimes you want to insert a bougie inside. There's a tube exchanger you want to insert inside. Sometimes you insert forceps inside the oral cavity to put throat packs or some various other reasons. So these instruments tend to get stuck in the Murphy's eye, and that is very problematic sometimes. Okay, so these are the disadvantages of Murphy eye. But do all the tubes have Murphy's eye? Do all the tubes have Murphy's eye? The answer is no. So there are basically two types of tubes. Okay, one which has Murphy's eye and one which don't have Murphy's eye. Which don't have Murphy's eye are called as Nagel's type of ET tube. They don't have Murphy's eye. Okay, so what modification is made in the tubes which don't have a Murphy eye? Simple, I'll show you. When there is no Murphy's eye, basically what they do is, the cuff. If Murphy eye is not present, the cuff is usually placed closer to the tip. This may decrease the risk of inadvertent bronchial intubation. All right. Okay. This will reduce the risk of inadvertent bronchial intubation. Okay, so here we end the chapter of Murphy's eye. We'll go forward. Okay, so we'll just discuss once this slide. What are the markings on the endotracheal tube? Okay, so the first marking we can see is it shows whether it is the oral or nasal indication. Okay, in some tubes this is there. Then we see the tube size. Usually it is in millimeters, or French size. We usually see it in millimeters. Okay. When the tube is 6 size and smaller, especially for the pediatric airway, you can also see the mentioning of external diameter. Usually we see 7 mm, 7.5, 8, 8 point, whatever tube size you see, that is a marking for the internal diameter of the tube. But for the tube 6 size and less, there are marking. The marking also shows the external diameter of the tube. Okay. In cuff tubes, the size is marked on the pilot balloon as well. You can see on the pilot balloon, the size will be present there. And in uncuffed tubes, the size is also marked near patient center. Okay, there are lots of this I have taken from Bahiti, but we all know that there are slight modifications here and there. We see markings on patients and also we see a lot of things, but for theoretical purpose, right? Okay, we have manufacturer's name, we have a radio opaque line, we have a transverse black line. Okay, at the end of the tube, when this is the tube, this is the bevel, and here there's a line. Okay, what does this line indicate? Which I'll try to show you in for the photos. Okay, here there's a line. There's a line which would be present here. What does this show? This line. Okay, this line basically shows the this line basically this line is present. What it is present proximal to the cuff. This line is present proximal to the cuff, and what does it show? That it is properly placed in the trachea. When you intubate the patient, while intubating, you see the through your vision, you see this line, transverse line going inside. You know that it is properly positioned. It is not deep. It is not out. It is properly positioned in the trachea. So that is the use of this transverse line, which is present at the patient near the cuff, near the patient's end. Right. Okay. All right. So we are gonna see. We are gonna talk about the materials with which tracheal tube is made. All right. So the materials, we can see three types of materials here. There are three types of tubes here. This tube is made of something called as red rubber or natural latex. This is made of polyvinyl chloride, also called as PVC, and this is made of silicone rubber. You can see these are three different materials. So these three different materials will be having different properties, different advantages and different disadvantages. All right. So first talking about the red rubber tube. Okay. See, talking about the red rubber tube, first we'll talk the advantages. See, we can see this is a rubber. So definitely it is reusable. Okay. You can use it again and again. And other advantages, you can actually the thing is that it is less traumatic. Why? Because it is adequately rigid. We're talking about lattice tube. The advantages is it is reusable. You can sterilize it and you can reuse it again and again. And second advantage is that it is adequately rigid. It isn't too rigid, not too kinking. It is adequately rigid. So, but it has disadvantages also. All right. So, what is the first disadvantage? All of us can guess. Yes, definitely. It is made of latex, so could be allergic to some people. All right. Second, it is opaque. Okay, you can't see through and through. So after cleaning, you can't actually tell that it is properly cleaned or not, because you can't see the internal lumen. Okay, there could be times when something could be dislodged, or some secretion or something. You can't actually tell. It is opaque. And second, if you use on repeated use, if you use it repeatedly, it becomes soft and later kinks. This is another disadvantage. Okay, and the one more big disadvantage is it requires high cuff pressure. All right, to keep it in position, you need a very high cuff pressure. So with this, we finish the latex tube, the red rubber latex tube. Moving forward, we will talk about the polyvinyl chloride tube. Okay, this tube all of us use every time for endotracheal intubation. There's nothing much I can tell you about. All of you know it is. We'll talk about advantages. It is inexpensive. It is not really very expensive. I think 70-80 rupees per tube. Okay. Second, it is less kinkable. Okay. It is sorry, it is non irritant. Okay. It is transparent. This was a disadvantage in red rubber latex tube. We can actually see through and through, and if something is dislodged, we can actually clean it, or we can do something about it. Okay. And it is, and one more thing is that uh, it is actually disposable. You don't need to you don't need to keep reusing it. You don't need to keep reusing it, sterilizing it, and reusing it. It's just disposable. You use it once and you throw it away. We'll talk about disadvantages of this tube. What are the disadvantages? The disadvantages, definitely, it is quite rigid, so it will be less elastic, more rigid. This is one disadvantage. You can't actually move it so much. It is quite rigid, right? And because of this, there is one big disadvantage. There is increased chance of trauma. If you do too much maneuvering, definitely it has a higher incidence of trauma. Moving on to the next tube, we'll talk about the next tube. This is the tube, which is also, this tube is made of silicone. Okay, so again, it is opposite to latex tube. The latex tube had allergic, and if someone is allergic to latex, you can either use polyvinyl chloride or you can use non-latex tubes like silicone rubber. This non-latex. One more advantage is that there is decreased surface for adhesion. It doesn't stick. It does not get stuck. Like, it does not stick to surfaces anywhere. It is quite smooth. It is not latex. Okay, and the similar feature with the red rubber latex tube is this is also reusable. You can sterilize it and you can use it again and again. This does not have any provision. Okay, and it is durable. It has a smooth surface. Okay, again the disadvantage would be the same. It is opaque. It is similar to red rubber latex tube, but different material, different level of elasticity. Okay, this also has quite limited flexibility. All right. So with this, we discussed the three types of tubes. The three, not the three types of the tube, the three materials which are made, with which tubes are made. All right. Moving forward, this is a table which will summarize what I have just told. Okay. Moving forward, now we are going to discuss about tube size. Tube size, all of us know. For females, we usually use 7.5. For males, we use 8 to 8.5. This I'm talking about the internal diameter. If you use a larger tube, you risk injuring the vocal cords. Okay, and the patient would complain of hoarseness, sore throat. And if you put a smaller tube, you are definitely going to face challenges during ventilation. There will be more leaks, and for that, preventing the leaks, you need more higher pressures, and you might also need to increase the cuff pressure, which will again have its own effects on the mucosal surface. Okay, so this is something about pediatric tube we are going to discuss. Okay, so sorry, this is the pediatric tube which we'll discuss. Alright. So in pediatric tube, we mostly use uncuffed. We don't use cuffed tubes in pediatric, and there's a point on audible leak. Okay, we use a tube small enough to leave an audible leak between the tube and the wall of trachea at high peak airway pressure, that is 20 to 25 centimeter H2. This is a small space that is left for audible leak. Okay, now we all know that the narrowest part in a child's airway is the cricoid ring. What significance does it play? So what you see is when you try to intubate a pediatric patient, you lift it with the handle, and you can see a bigger opening. You can see a bigger laryngeal opening. Okay, and you say, okay, we might be needing a tube of 3.5 or 4, and when you try inserting the tube inside, you get stuck at a point. Okay, and what you have to do is that you have to stop intubation and try a smaller tube at that time. But if someone tries to maneuver it too much, you might cause edema, and that point where tube is getting stuck is the cricoid, because the pediatric airway is such a shape that the cricoid, the complete ring cartilage, is the narrowest point of the airway. So when you try to force the tube inside, you're gonna damage the cricoid cartilage. Okay, and what will it lead to? It will lead to edema of the laryngeal inlet, edema of the laryngeal pathway. Your airway will become narrower. Okay, so what difference does it make in pediatric patient? When in an adult, 1 mm of circumferential swelling reduces the diameter of the adult airway by less than 10%. If you do in an adult patient, the diameter will reduce less than 10% if you get stuck or you try, if some trauma happens. But in an infant, the same injury, the same amount will cause the narrowing of airway by as much as 30%. Okay, and I'm talking about just 1 millimeter of circumferential thickening. Okay, so you need to be very careful with these patients. You need to be very careful with the pediatric patients. You need to see appropriate. You need to have good skills. You need to have a trained person beside you. You need to have the most senior person. And one more thing is that this the tube which you use should be calculated. Okay, and sometimes there is variation in the calculation tube size you use, but to a good extent the calculation helps you in identifying the correct size of the tube. Okay, so the most commonly used formula is this, which I'm going to tell you about. This is for patient below 6 years, you use age by 3 plus 3.5. Above 6 years, you use age by 4 plus 4.5. To calculate the internal diameter, okay, sorry, to calculate the internal diameter, you have if the patient is less than 3 months, 3 to 9 months, more than 9 months, and above 2 years. If less than 3 months, internal diameter should be 3 mm. 3 to 9 months, internal diameter should be 3.5 mm. More than 9 months, you can calculate by age plus 16 by 4. And for age above 2 years, you can use something called as modified Cole formula, which says age by 4 plus 4, age by 4 plus 4. And last, external diameter. We all know this. We use it same width as the distal phalanx of little finger. We use this little finger of the baby, and we can imagine we can assess the size of external diameter with seeing the width of distal phalanx. All right. If you but in case you use cuffed tubes in pediatric patients, there's something called as Kine formula. It is by age by 4 plus 3. It's less used, but it's good to remember. Moving on. Okay, बहुत हो गया. चलो, हमने क्या क्या डिस्कस किया अब तक? हमने ट्यूब देखा, हमने ट्यूब के पार्ट्स देखे, हमने ट्यूब के मार्किंग्स देखी. We saw the bevel, we saw Murphy's eye, we saw how to calculate the size of the tube. We saw what are the challenges we face in pediatric patients with the tube, and now we are gonna see about cuffs. Bevel हो गया, Murphy eye हो गया, size हो गया, cuff. Alright. This table is taken from Baheti. This is approximate size of tube as per age. Premature, you use 2 to 2.5. Neonates, 2.5 to 3.5. 1 to 6 months, 4 to 4.5. 6 to 12 months, 4.5 to 5. 1 to 4 years, 4.5 to 5.5. 4 to 6 years, 5.5 to 6.5. 7 to 10 years, 6.5 to 7.0. And 10 to 14 years, 7 to 7.5. Alright, moving on. Alright, see, now we are going to talk about one important thing uh, which even we get asked a lot as residents: cuffs. Okay, so what are the, you can see there are two types of cuffs here. All right, the first cuff is, you can see it is low, sorry, this low volume and high pressure. Second is high volume and low pressure. Okay, what are the differences? We are going to talk one by one. See, first I'm going to tell you about low volume high pressure cuff. Forget 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 this for some time. Okay, just we are going to talk about low volume and high pressure cuff. Okay, forget the other part. We are going to discuss one by one. All right, see, this is how it is: a thick inelastic material. From the name we can understand, it requires less volume. The volume of air which is present inside it requires less volume, and the pressure which it exerts on the mucosal surface is quite high. So what will happen? Number one, because of low volume, the shape which is inside it looks little circular. It does not fit with the mucosal surface. It is circular. Okay. Whereas the other cuff, you'll see it quite fits with the mucosal surface. I'll tell you about that later. But now, for now, you see that it is circular in shape, and it does not conform well to the tracheal shape. Okay. The area of contact. You can see the area of contact. This is the area of contact. The area of contact is quite less, right? The area, there's a small area contact with tracheal wall, and what does this lead to? It distends the trachea circularly. The trachea is distended circularly. It is circular in shape. The trachea gets distended circularly. There's high pressure on the adjacent tracheal walls, and what will that do? It can lead to the risk of mucosal ischemia. The mucosa of the trachea can get ischemic at times. Okay, and because of such high pressure, there can be a complication which is called as tracheal stenosis. Tracheal stenosis. तो ये tracheal stenosis की असुविधा बढ़ा देता है. Right? Now, it's not all bad. Okay, there are certain advantages of it also. What are the advantages of this type of tube? Okay, number one, see, you can see better protection against aspiration. It is definitely going to provide you a better seal, so you don't risk aspiration as much as with the other type of cuff. Okay, then second is the vision that is better. You can see the tube better, you can see the cuff better. Okay, then there is reduce in sore throat as compared to that. Okay, all right, these are the benefits which you get with this cuff. It is not routinely used now, but still, if you use, these are the advantages which you get with the cuff. Now one thing is there, that there can it can form it can form micro folds and micro channels. Okay, so if that happens, it leads to risk of ventilator associated pneumonia. You know, when patients are in ICU and you put this for prolonged phase, it can increase the risk of ventilator associated pneumonia. And also one more thing, something is called, I want to discuss something called as nitrous oxide effect. I tell you something called as nitrous oxide effect. This is present in both the type of tubes, what happens is that the pressure increases due to nitrous oxide diffusion. This diffusion of the nitrous oxide which further increases the pressure inside the trachea. All right. And now one more thing, and last point is something cuff overinflation. The In the low volume, high pressure type of cuff, it can overinflate, which can lead to high intracuff and tracheal wall pressures. This is a complication which is present in both of them. If you overinflate the cuff, definitely it is going to cause increased pressure on the adjacent tracheal wall, and it can, damage the tracheal mucosa. That is present in both. Okay, even LVH, low volume high pressure cuff, and low pressure high volume cuff, both can overinflate, which can lead to high intracuff and tracheal wall pressures. So with this we conclude the low volume high pressure cuff. Summarize. I'll just summarize it once for you. It is circular in shape. Okay, one, why it is circular in shape? It is thick in elastic material. It requires high pressure and small volume. It does not come well with the it does not conform well to tracheal shape. There is a small area of contact with the tracheal wall, and it distends the trachea circularly. There is a high pressure within the cuff, which risks the patient for mucosal ischemia, tracheal scarring, and stenosis. Okay, but the benefits are it has better visualization. It has better protection against aspiration, and it has a lower incidence of sore throat. Other thing is, it may contribute. And the common points between this and the other type of tube is both can contribute to ventilator associated pneumonia. Both have nitrous oxide effect, and both can cause cuff overinflation. Not talking about high volume low pressure cuff. Okay, this was thick in elastic. This is thin and inelastic. Okay, this adapts to tracheal surface. Okay, there it was globular, here it is not globular. Okay, there is a large area of contact with tracheal wall. All right, it is thin, it is inelastic, it adapts to the tracheal surface, and there is a large contact area. Okay, within the cuff there is low pressure. Okay, more volume. Okay, the pressure is low, because of which there will be reduced mucosal ischemia. Mucosal ischemia will be less, there will be less chances of tracheal stenosis. Okay, but talking about disadvantages, definitely it is going to be less protective for aspiration. Okay, it may obscure tube tip and larynx, which makes its insertion harder. The cuff is quite big, so it might sometimes get stuck at the glottis opening, and you might find difficulty in intubating the patient. And there is a higher incidence of sore throat as well. Other points which we discussed of ventilator, there is a higher chance of sore throat and less visibility. These are the points. Okay, the nitrous oxide effect, which is the pressure which will increase due to nitrous oxide diffusion, that will be the same. The cuff overinflation point will be the same, and the chances of ventricular associated pneumonia will be same. All right, both in. All right. So now coming back to this diagram. All right, we have discussed bevel, check. We have discussed cuff. We have discussed Murphy's eye. We have discussed these things. We have to an extent discussed the sizes. Okay, now what is left? We are going to discuss about the tube. We are going to discuss about this pilot and this connector. Moving forward. This is the table which will summarize what all I said. the difference between low pressure, low volume, high pressure cuff and low pressure, high volume cuff. Okay, yes, there are some different types of cuff also which we will try to discuss. One is foam cuff. Okay, what is this foam cuff? This thing here, it is foam, made of polyurethane foam. It has a large diameter and the residual volume, which is when compared with other cuff, it is a larger diameter and more residual volume. How is it deflated? It is deflated by suction, expands when pressure is released. You actually, when you aspirate it, it gets deflated, and as soon as you leave the syringe, it again expands. Okay? The foam expansion controls pressure on the tracheal wall. Okay, there is some inverse relationship. More the foam expansion, lower the tracheal wall pressure. Foam expansion, if the foam expansion is more, the pressure on the tracheal wall is less. It's okay. And one more thing is it provides good seal at lower tracheal wall pressures when used properly. Definitely, if it expands more, the tracheal seal will be. This was the advantage which the high pressure cuff gave. It made a good seal. Okay, but the damage which came along with it is it caused tracheal. It caused the ischemia of the tracheal mucosa. But this, it will provide good seal also when used properly, and the tracheal wall pressure will also be less. All right. Moving forward, there is something is called as lance cuff. What is lance cuff? Okay, okay. We can see here this is the lance cuff. Okay, so you can see that it looks quite different when seen along with a normal pilot balloon. Okay, so what does this do is it contains a latex pilot balloon inside a transparent plastic sheath. This is lance cuff. It contains a latex pilot balloon. The pilot balloon is inside a plastic sheath. All right. Okay. So what happens is there's a pressure regulating valve which maintains intracuff pressure of 20 to 25 torr at end expiration. The valve allows gas flow between the balloon and the cuff, preventing leaks during positive pressure ventilation. There is a valve present which allows gas flow between the balloon and the cuff. Okay, this plastic balloon and the cuff, uh, there's a gas flow in between them. Okay, and this will prevent leak during positive pressure ventilation. Okay, with this, one thing is there that the pressure between the cuff and pilot. Okay, when you are giving positive pressure ventilation, you might increase the pressure. You are definitely going to increase the pressure inside. So normally in other tubes, what you need to do is you need to measure the cuff pressure sometimes, which we don't usually do. But theoretically, we need to measure the cuff pressures with the help of this type of balloon. This is the pilot. Okay, and surrounding it is a plastic sheet. Okay, so the airflow is there between both of them, which maintains the pressure. You don't actually need to measure the cuff pressure separately for adequate safety. This is the beneficial mechanism in lance cuff. Okay, and it may not but the disadvantage is because the cuff pressure is quite what we say, it is quite you can the cuff pressure is changing itself, so you can't actually rely on it in situations where you need high tracheal cuff pressures, because there's increased risk of aspiration. This will definitely increase this tube, the lance cuff. Because of lance cuff, there might not be a good seal in patients which need high airway pressures. Okay, and definitely overinflation or compression can lead to increased cuff pressure. All right, moving forward, I will not discuss this in too much detail. This is something called as cuff pressure manometer. Okay, what does cuff pressure manometer do? It actually measures the tracheal cuff, the pressure inside the tracheal cuff. I have personally never seen it. It's just theoretical. Okay, what is the optimal cuff pressure? This is important. The optimal cuff pressure is 18 to 25 mHg on lateral tracheal wall. Okay, now what is leak test? Leak test we do routinely. What is leak test? Okay, see, valve on breathing circuit is partially closed. Bag is squeezed until an audible leak is heard. The valve in the circuit, the APL valve is closed partially, and you squeeze the bag and you keep a stressor on the neck and you see audible leak when audible leak is heard. So pressure at the leak is equal to pressure exerted by the tube on tracheal wall mucosa. So with which pressure you hear an audible leak. Okay, you see the pressure at the time when you hear the audible leak. That is the pressure which is exerted by the tube on tracheal mucosa. So that is called leak test. In children, we use lower pressures to prevent tracheal ischemia. Something we'll talk about, nitrous oxide effect. We talked about it previously also. What it is? Nitrous oxide effect. It is basically the intra-cuff pressure increases due to diffusion. The nitrous will diffuse and this will lead to increase in intra-cuff pressure. And as soon as you discontinue the nitrous oxide, the pressure will decrease rapidly. All right, and you can actually monitor the cuff pressure manually also by palpation of larynx or the pilot balloon. You can actually feel the pilot balloon and say that the cuff pressure is high or not, and definitely other ways using this manometer. All right, some small differences between cuff tube and uncuffed tube. Uncuffed tube is mostly used in children, cuff tube is mostly used in adults. The advantages in cuff tube is definitely one, it decreases the risk of aspiration. You can use it at higher inflation pressures. The fresh gas flow, it requires low fresh gas flows. Okay, and you can do accurate monitoring of end tidal gases and tidal volume. There will not be much disparity because there is low leak. When there is a leak, there will be disparity in the tidal volume delivered and tidal volume measured, the expected tidal volume measured. Okay, here the advantages is it is preferred in young children. Why? To prevent airway obstruction damage. Definitely, if there is a cuff, it will be to increase risk of tracheal ischemia. There could be airway obstruction. The disadvantages is it requires slightly smaller tube size. Okay, there is a risk of overinflation and there is a risk of vocal cord injury. Here, there is increased resistance and work of breathing. In uncuffed tube, the work of breathing becomes more as compared to the cuff tube. Moving forward, so we have discussed the tube also now. Okay, we have discussed sizes and we just discussed with you the pressure, the tracheal pressure. Each and everything about endotracheal tube is discussed in depth in our lecture. We definitely welcome all your criticism and all the, see, I am also a resident, all right. So I have read about this, I try to discuss it, and I'm definitely going to face a lot of criticism, and that's totally fine. Okay, but what my goal is that what we use in day-to-day life, what we use daily, the syringes, the infusion pumps, the machines, the monitors, the drugs, all that we can discuss so that if we can connect with lot of residents and we can actually, what we see is we go to the OT, someone teaches us take this tube, put it inside, and that's it. No, we are not just supposed we should not just be limited to that. We should be knowing each and everything we touch, each and everything we see, each and everything we use. Each and everything should be known by us. Even I am in learning process. I am still not a very expert in this, but with साथ सीखते हैं, साथ सीखेंगे, साथ बढ़ेंगे, साथ बनेंगे, है ना? ठीक है, चलो, we'll move forward. So now coming to the proximal end. Okay, again going back to our diagram 0. Okay, see, now we'll talk about this proximal end. Alright, this is the proximal end. So here either you can connect this connector. Okay, you can see this connector which you can connect here, or you can also connect something called as catheter mount. We are going to see each and everything in detail. All right, coming back to our normal place. Yes, so this normally we use a connector. What is this? This is a connector. What is the role of this connector? Number one, it connects a tracheal tube to the breathing circuit. You just can't connect directly the endotracheal tube in the breathing circuit. You need a connector. Okay, and it could be either made of plastic or it could be made of metal. It could be made of, and see what if this is the connector, there is some internal diameter of this connector. Okay, the size of connector is actually based on its internal diameter. Okay, and the machine end is standard. From the machine, the connector will the machine point which will connect the circuit where it will connect to the endotracheal tube is standard. It is 15 male fitting. Okay. So to check the compatibility, the connector size must match the size of endotracheal tube. The SNA, it shouldn't be like connector is too big and endotracheal tube is too small. Like for a 7 size tube, the appropriate connector should be used. For a pediatric tube, appropriate connector should be used. Okay, there are two types of connectors. One, here we can see this is the straight connector, and this is a right angled. Sorry about this. This is a right angled connector. This. So there are two types of connectors. Where do we use straight connectors? We normally use it. We use it in all the surgeries. And where we use the right angle connectors, we use it. I have never used it, so I don't know technically. But in textbook, it's written. Examples include Magel's connectors, raw Botham connectors, and Noseworthy connectors. I don't know what they are. See, you can definitely put it in comment section where we use right angle connectors, and I can to learn from it, and I will definitely pin your comment. Okay. Okay. Now, because all the tubes are disposable, so we don't actually measure for each and every one. There's a standard connector, which is the universal connector, which we use in all the tubes. Okay. Now we'll talk about catheter mount. This catheter, see, how is catheter mount attached exactly? See, this is the endotracheal tube, and here we can see this is the connector. It has a 15 millimeter outer diameter, and with that, this part where it starts, this is the catheter mount. Okay. Sometimes when you, for cases like oral surgeries or surgeries where there is a lot of head movement or the whole surgery is positioned towards your head and neck, so in that time the tube motility should be reduced, to prevent accidental extubation or prevent help surgeon in proper positioning. So in that situations, to extend the circuit, you actually use a tracheal mount. All right, it will reduce the movement of the tube. That catheter mount is also either metallic or it is of plastic. What I have used is of plastic. I have never seen metallic catheter mount, but it does exist. All right. We are going to talk about some special tubes. This is the last half of our class. Okay. This is cold tube. It is used in emergency neonatal resuscitation. Okay. There is no cuff. It is uncuffed, and it has a smaller end. Okay. The in it the shoulder at the uncuffed oral tube with smaller patient end. Shoulder at the junction prevents bronchial intubation and provides airtight seal. The same internal diameter as the patient end size, higher resistance than a standard tube, causing potential larynx trauma. If the see the this is quite, see, I've never seen this tube, to be honestly. What I have read and what I'm trying to explain is all that I mean. The tube is narrow, so there will be more resistance while delivering the tidal volume. Okay, the internal diameter will be same as the patient. Okay, it is not suitable for nasal intubation. It is just mainly used for neonatal resuscitation. You have to secure an airway. That's it. After that, you change this tube and you can come back to your normal uncuffed tube. Okay, and this obviously you can see that there's a narrowing here, and this will increase the risk of blockage. Okay, because the patient end is quite narrow. All right, moving forward, this is the Coles tube. In short, Coles tube, narrow patient end, more airway pressure is required. Okay, there's a higher resistance, there's increased risk of larynx trauma, and its biggest use is just emergency neonatal resuscitation. That is, this is its main use. Moving forward, this is the micro cuff endotracheal tube. The cuff is very micro. It is designed for children. There's a short, ultra thin polyurethane cuff located away from subglottic area. This cuff seals the tracheal wall at low pressures, approx 10 centimeter of water. It is inflated with a 0.1 ml air at a time, and continuous monitoring of cuff pressure is done. Okay, there is no Murphy's eye, and this further reduces the risk of required ring pressure and mucosal trauma. Moving forward, okay, this tube is quite interesting. Okay, this tube is quite interesting. This is called as ring Adair Elvin tube, RAE tube. See, I was in the Viva. Okay, my semester Viva, this terminal exam Viva, and ma'am, my professor, she told me to pick this tube. Okay, um, and she told me to pick and find an endotracheal tube in the box of instrument. Like there was a box. Okay, there were a lot of things kept inside the tube, and I just had to put my hand inside, and I saw like pilot, and I just thought there's an endotracheal tube inside, and I'll just pick it up and just talk about it. But as soon as I picked the tube, I saw a very different kind of tube. It was something bent here and there, and I didn't know what the hell this is. I was so shocked, and my faculty started laughing because she knew that I screwed up. I picked up the wrong tube. She asked me to pick an endotracheal tube, okay, and I had to pick the easiest one, the one which we all use, the polyvinyl chloride endotracheal tube. But somehow I managed to pick the RAE tube, and I was asked, okay, now tell about this. I was clueless. I was totally clueless. But now I have studied it. I might help it. I have not used it so much, but I'll try talking about it. Okay. So basically, coming back, uh, this is the north polar, and this is south polar. See, it is facing up, north polar. This is facing down, south polar. Okay, as we can see, first we'll talk about north polar. This curve which you see. It is a cephalic curve. What do you mean by cephalic curve? It directs the tube towards the forehead. Okay, the curve is upwards. It directs the tube towards the forehead. And where is this used? Hmm? You know, it is. This tube is used for surgeries on the lower face, on the mandible and floor of the mouth. It may be also useful in surgeries where patients are prone. Okay, the north polar tube is therefore also called as nasal RAE tube. Okay, it is also called as nasal RAE tube. The tube, the risk in this tube it is small and too short in smaller children, which can lead to bronchial intubation, and it may be too short for some patients, and it might increase the risk of accidental intubation. Now, talking about the oral RAE tubes, or also called as south polar tubes, they are bent at an acute angle. There is an acute angle. Okay, they are bent at acute angle, and they rest on patient's chin. Okay, and they improve access on the surgeries in the face. You don't When there are surgeries on the face, you normally there are a lot of movements in the tube and all, but this tube, the oral RAE tube, is different from nasal RAE tube in point number one. Uh, it is uh, um, it is actually acutely bent. This is not acutely bent, but this you can see it's a proper U-turn. It's an acutely bent, and it rests on patient chin, and it improves the access for the surgeon on surgeries involving cleft lip, cleft palate, nasal surgeries, and this also reduces risk of accidental extubation. Okay, and what is the difficulty in this tube? You can see since it is so much bent, you can't actually pass a suction catheter through it. It will be difficult for you to pass. There will be a lot of resistance, and normally also because of so much tube, so much curvature, during ventilation there will be more resistance to the gas flows. So in short, oral RAE tube and nasal RAE tube are these points. See, oral RAE tube is bent at an acute angle. It rests on patient chin and improve access in surgeries of face. Whereas nasal RAE tube, it is cephalic curve. It is curved towards the forehead, and obviously it reduces the pressure on the nares. Okay, I have talked about where these surgeries are useful. Nasal RAE tube will be, since it is positioned upwards, it will have better the surgeon can have a better the tube is faced upwards, so surgeon can actually have a better visual field for the surgeries involving lower half of face, such as like surgeries for the mandible and like floor of mouth. All right. And when the patient is prone, also, uh, it is quite helpful. Okay. The only risk being there is a high risk of accidental extubation in this north polar tube, and for children it might be too short. Okay. And it might be smaller in diameter and can lead to bronchial intubation. Okay. And the oral RA tube is definitely bent so much that you can't actually pass a suction catheter, and any tidal volume you deliver will face higher resistance. Okay. But since you can see, if it passes inside, it actually, when you pass a tube inside, it rests on the chin of the patient. It rests on the chin of the patient, and the upper mandible surgery, sorry, I'm not the upper mandible, I'm sorry, the hard palate surgeries like cleft palate. Okay. And surgeries involving the nasal area, these can be done very smoothly. Okay. In general, both are cuffed and both tubes have various sizes. Okay. And both tubes may not fit in patients properly sometimes. Okay. It can be too long or too short. And this is all about both oral and not oral, or nasal and oral RA tubes. Moving forward. Okay. We all know this is a flexometallic tube. Okay. Flexometallic tube, we all have used it so much that in oncosurgeries and surgeries and ENT surgeries, thyroid surgeries, we have used this tube a lot. Okay. It can either be made of rubber or it could be made of polyvinyl chloride. Okay. There is less kinking. Okay. Kinking is, sorry, there is less kinking. Okay. You can use it in head and neck surgeries. Okay. With this tube, the advantages are, you can easily pass a fiber scope through this. Okay. Unintentional extubation is reduced. The risk of, because it is so flexible and so kinking that it usually during surgery there is a reduced risk of accidental extubation with this tube as compared to the other type of tubes. Okay. And but one thing is that you can't actually modify it too much, because there's a metallic wire inside. You can't shorten it, or you can't do it. It's a fixed. Okay. And it becomes little difficult to pass through the nose. Okay. And the wall is quite thick. The wall of the tube is quite thick, so the internal diameter of the tube is quite narrow. Okay. And if you can definitely repeatedly use it, but it makes it soft, and if it becomes soft, there's an increased risk of kinking of the tube. There is no Murphy's eye, which will lead to potential obstruction if bevel abuts tracheal wall. Definitely, if there's no Murphy eye, there is no side port for ventilation, and if it gets occluded the bevel, it's screwed. And um, in some spine surgeries, okay, you want to do cervical spine surgeries, or you can when you want to take C-arm and all that, the metal spiral wire will come in the photo of the field, and it is definitely going to cause some problem to surgeons. Okay. You can't with the x-ray, with the C-arms and all that, the metal will come in between their spine, in between their spine nails and all that, and it is a quite problematic in this situation. So it is made up either that is also either rubber. It is made of rubber or PVC. Okay. Now in short, we'll see this is the Oxford tube. Okay. I want just give a reading about it. Okay. Then one more tube is, we see this is an MLS tube. Okay. Microlaryngeal surgery tube. For laryngeal, sometimes there is microlaryngeal surgeries done to take biopsies or some small minor cyst or some excision. Okay. In such situations, we use microlaryngeal surgery tube, also called as MLS tube. Okay. This is an important question, that what is the internal diameter of this tube? The internal diameter is approx 4, 5 or 6 mm. Okay. And it's a high volume, low pressure cuff. Okay. It is for microlaryngeal surgery, as I told. Okay. The smaller tube diameter improves visibility and access to the surgical field, and it can be used for nasal intubation or intubation via LMA or other supraglottic devices. The diameter of the tube is small, okay, in this thing, but the diameter of the tube is small, but the cuff which is present in the tube, it has a higher volume and low pressure. The volume will be too much, so seal will be created with the cuff, okay, and the ventilation could be provided with the narrower tube. So what benefit it provides is that the vision of the glottis area increases. You can actually access this area for surgery, and and with the normal ED tube, what happens is the tube internal, the diameter of the tube is more, the cuff is less. So you can when you share the airway with an ENT surgeon, there could be lot of potential threats for accidental extubation. There could be harm during the surgeries, but with this tube you are safe. Okay. Second, the material of this tube is not the PVC. Okay, so it is like it's like a rubber or latex type of tube. Okay, so what happens is that when the surgeon uses the cautery, there is a less risk of burns. Okay, but one disadvantage is you can't actually use it with lasers, and flexible nature makes insertion difficult without Magel's forceps. Definitely. These are some different types of tube: Tehran tube, Cardan tube. Okay, you just see the images and once read the slide. It's not something which we daily use, but just because it's present in Bahati, it is once worth mentioning. Okay, Tehran tube. This is something Cardan tube. Then we have Hunsaker Monjet tube, a laryngectomy tube. Okay, these are the images, and then there is something called as endotracheal tube, endoflex tube. I have never seen this type of tube. This is the endoflex tube on the right side. I'll show you it. This is the endoflex tube, laryngectomy tube. All right. Then endotracheal tube. There's a Parker flex tube. I'll show you about the Parker flex tube in the further slide. Okay, Parker flex tube, and then there's something called as electromyogram reinforced tracheal tube. Within the tracheal tube you can see these wires. Okay, there are lots of wires which are put through the tube, and that is called as electromyogram reinforced tube. Okay, and this is quite interesting. Intubating LMA. This thing will be discussed in depth when we discuss about the supraglottic airway devices and tracheal intubation. For now, you just see it that this ED tube on our screen is called as intubating LMA. Okay, ILMA. Okay, this thing is about intubating laryngeal mask tracheal tube, which I just told you about. Okay, we are going to talk about it in depth. For now, just know about it a little bit. It comes in various sizes. Okay, it is easier to advance over a fiber scope, and you can the biggest benefit is you can use it in submental intubation. Okay, this is preferred over PVC as compared to normal PVC tube. It is quite flexible, and you can use fiber of scope and all with this. Okay, but as I said, we are going to discuss it too much in depth when we discuss it with supraglottic airway devices. Okay, these are some key features and drawbacks of the tubes I have just mentioned. Okay, so these are some special kind of tube which we rarely use: the laser shield, high flow evac. Okay, laryngotracheal installation of tropical anesthesia tube. There are lots of tubes like this. Okay, so you can actually go through the summary of these tubes, but the most common tube, the most important ones have been discussed. Okay, and you can actually know the names of these tube if you can, but that's it. With this, we will wind up our lecture on the endotracheal tubes. I hope that this lecture is beneficial, and I've tried to make my point about endotracheal tubes so that we are not so clueless when we use them. Okay, and all these have been taken from Bahati. You can see it, if you can actually go through it. It's quite easy language. It's quite written in easy language, and thank you for being here, for patiently waiting if you have come till this point of the lecture. Thank you.